Namaste. Good evening, everyone. This program of Guru Vidya is being conducted as a mark of respect to our teachers on whose shoulders we have grown tall. This program is basically to share the education that our teachers have given us with all of you so that you all become better clinicians and are able to improve your patient management. Today's topic is a very common topic, that of systolic hypertension. All of you, in fact, a large number of your would be uh, patients would be having hypertension, and in your day-to-day practice, you will be facing a lot of patients with different presentations of hypertension and management of hypertension. Now, the discussion which I'm going to make is basically to share with you our clinical cases and simplify the process by which we can have better management of patients. Let me begin by sharing 2 or 3 cases which we have had in the past. Last week we had one young boy. He was around 45, 46. He reported to us with slurring of speech and inability to, the relatives could not apprehend what he was talking. So he was brought to us. This gentleman, in fact, unfortunately, was born with severe birth defects of very short upper extremity. They were birth defects. But he was never having any hypertension or diabetes in the past. When we recorded his blood pressure was 220 by 110. We got him investigated, and fundamentally it was, we were wondering what is the cause of stroke, but it was hypertension which presented to us as a case of stroke. Fortunately, the patient did not have any hemorrhage. We controlled the blood pressure and the patient recovered and went home. This was one case. Another case who came to us, he came for a second opinion. He was playing cricket on a cricket field, and this gentleman was 52-year-old gentleman, and someone hit the ball, and he thought that he's very young, and he tried to get hold of the ball, and as he tried to get to the ball, he lost his balance and he fell down, and then he was taken to a nearby clinic where they examined him and found his blood pressure again to be at 210 by 110. He had no previous history of hypertension. And there were some minor ECG changes. From that, they went on to do his angiogram, had some borderline lesions, was advised an angioplasty. However, patient had no symptoms, cardiac symptoms at all. So in view of the fact that patient had borderline lesions, we controlled him on medicines and advised him to follow up on a regular basis with lifestyle modification. This is another example of a patient who's asymptomatic, presenting suddenly with symptoms, and investigated further down to realize that he's got some ischemic heart disease. But I think the patient required more of management of his lifestyle and medications. The third patient is an elderly patient. He's about 77, 78. And this gentleman, whenever he gets up at night to pass urine, he drops down. And he has to be helped and taken to the bathroom and subsequently got back. He was admitted, he had come to the clinic and he was admitted for a few days because when we recorded his blood pressure in supine position was again 220 by 120. In sitting position, it was 190 by 100. and in standing position, the blood pressure was 150 by 90. So this patient had a postural drop in his blood pressure. And subsequently, we give him certain medicines, mineralocorticoids, with which the blood pressure was reasonably maintained, but still he continued to have a drop. He had severe diabetes and had developed diabetic autonomy, autonomic dysfunction. And because of that, he used to get this postural hypertension. And any small dose of medication given to him to control his blood pressure would cause a significant drop. So managing this patient was always a great dilemma, because you give him little higher dose of medications and he goes into hypertension. And if you reduce the dose of medications, he goes into severe hypertension. At 78, 79, it's a clinical therapeutic challenge to manage such patients. So hypertension is a day-to-day figure, and the management needs to be individualized. Let us go through the discussion of hypertension. The prevalence of systolic hypertension is estimated to be around 35% in adults worldwide and may exceed 80% in those over 65. This condition is a primary contributor to cardiovascular disease, necessitating urgent attention from healthcare systems. So it is as frequent as 80% those people above the age of 65. The risk factors for systolic hypertension include obesity, sedentary lifestyle, high salt intake, excessive alcohol consumptions, excessive alcohol, genetic predisposition and environmental influences also play a critical role in developing this condition. Systolic hypertension exhibits significant demographic variations. Being more prevalent in the low and middle income countries, disparities are also observed among different ethnic groups, indicating a need for tailored healthcare approaches. Age-related hypertension. Age is a major determinant of developing systolic hypertension, with the incidence sharply increasing after the age of 40. Notably, elderly people who face a heightened risk of developing hypertension, largely due to vascular and comorbidities associated with aging. Now, what are the etiologies and signs and symptoms of patients presenting with hypertension? As we all know that hypertension can be of two types: primary hypertension and secondary hypertension. Primary hypertension is that in which there is no underlying etiology. We are not able to pinpoint a correctable cause. It is more related to maybe genetic factors or factors which cannot be modified. Primary hypertension accounts for about 90 to 95% of the cases, arises without any identifiable cause. Its development is okay, gradual, it's slow, gradual, and linked to complex interactions of genetic and environmental factors. And the second type of hypertension is secondary hypertension. Secondary hypertension results from identifiable medical conditions such as kidney disease, endocrine disorders, or certain medications. Identifying the underlying cause is crucial for management and treating such patients. Genetic factors play a very important role. And in fact, if there's a family history of hypertension, then your probability of developing hypertension is more. So therefore, one should do screening of patients who have a genetic history of hypertension. Lifestyle influences, one of the most important things today, or one of the biggest problem of urban living is poor lifestyle. And this is one of the most modifiable factors. Poor diet, lack of exercise, smoking and alcohol consumption, significantly contribute to hypertension. Implementing lifestyle changes can lead to a substantial improvement in blood pressure management. And as we come to the management of hypertension, I'll talk more about this later. Comorbid conditions such as diabetes, obesity, sleep apnea often coexist with hypertension. Sleep apnea is one of the most important factors which is now being detected and it was always an ignored condition. In fact, the moment you correct the obstructive sleep apnea with assistance in terms of a BiPAP, these patients they respond very well and is fairly effective in controlling hypertension and improving overall health of the patients. What are the signs and symptoms of patients with systolic hypertension? Common symptoms, typical symptoms include a typical symptoms of systolic hypertension can include headaches, dizziness, and blurred vision. Many patients may not experience noticeable symptoms until blood pressure reaches severe levels, emphasizing the importance of regular monitoring. In fact, some patients are fairly sensitive to changes in hypertension, in blood pressure, and the moment there's an increase in blood pressure, they complain of symptoms. But there are many patients who have practically no symptoms and present to you for the first time with severe hypertension. Physical examination findings, it is important the way you record the blood pressure of a patient. The cuff, which is ideally the blood pressure should be recorded in a lying down, patient comfortable, and in a very quiet environment where the patient doesn't have much of anxiety or a lot of disturbances. The BP cuff need to be tied in such a manner that there is no air in between in the cuff or in the between the cuff and the arm. The rubber tubing, which records, which comes out from the cuff, should be on the medial aspect, and the stethoscope should be placed appropriately over the brachial artery. It is very important to record the BP properly because if you don't take adequate precaution to record the blood pressure, you may have erroneous readings of the blood pressure. So during physical examination, other than blood pressure, you may find changes in the heart rate. Additional findings, which are very important, would be organ damage, which would require for further assessment. Organ damage, especially organs like the eyes, where you can have retinal changes, damage to the kidneys, damage to cardiac heart, and damage to the brain in terms of compromise in the vasculature of the brain. This would require further investigations on that front. The related complications, it is always said that hypertension is a silent killer. Untreated systolic hypertension can lead to serious complications, including heart disease, stroke, kidney failure. The risk increases significantly with prolonged high blood pressure, making effective management and appropriate timely management of blood pressure very important. Asymptomatic cases, many individuals with systolic hypertension remain asymptomatic until severe complications arise. The silent nature of the condition underlines the importance of regular screening, particularly in high-risk populations. Probably, I think maybe after the age of 40, one should get one's BP checked on an annual basis. And after 50, maybe once 6 months, you need to get blood pressure checked. Investigations and management of systolic hypertension. What are the tests which you need to assess the hypertension of an individual? The key diagnostic tests for systolic hypertension include primarily blood pressure management. Please see in this picture the right way of how the blood pressure is monitored. And the rubber tubings are on the medial side. The cuff is opposed firmly against the arm, and the stethoscope is placed in the brachial artery. It's important to take these simple measures to get accurate blood pressure reading. Diagnostic test would be first taken take an ECG of the patient to see whether the patient's heart, everything is wrong. In fact, the second patient which I mentioned, while playing cricket, this patient was asymptomatic, was found to be hypertensive for the first time, and was found to have hypertensive ECG changes. Ideally, patient should have undergone a control of blood pressure and subsequently got evaluated. But patient landed up on the CAT table, was an angiogram done, and was advised an angioplasty with IVS guided. I think it's very important to follow protocols, to guide our patients properly, and to treat them in a very ethical manner. After the ECG, one needs to do certain blood tests to assess whether there is any damage to the kidney. Lipid profile needs to be done. Fundoscopy needs to be done to check up on whether there are any retinal changes, and a test to find out whether there are any other cardiovascular risk factors. Treatment protocols for systolic hypertension begin with lifestyle changes. Now, what do you mean by lifestyle changes? I think it starts from a very young age. Physical activity is one of the most important part of lifestyle. Regular exercises, which could be maybe half an hour to 45 minutes. It could be as simple as just even brisk walking on a daily basis is good enough good enough exercise to increase the heart rate. But other exercises which can be followed could be simple jogging or swimming or cycling or skipping. These are regular lifestyle modification exercises these are important from cardiovascular point of view and helps in improving the overall cardiovascular profile of the patient. Second most important thing is obesity. I think as we go to urban settings, the level of obesity seems to be increasing on a regular basis, and it is very important to control and keep your weight within the acceptable limits. Excessive eating habits and urban lifestyle in terms of eating junk food causes an increase in obesity, and obesity itself is responsible for many other risk factors. It's an independent risk factor for a cardiac problem or hypertension or even diabetes. Keeping your diabetes under control is extremely important, and regular monitoring of HbA1c is very important because that also has an impact on the heart, and it can lead to hypertension. Very important is the diet of an individual. I think it's salt restricted diet is very important, and uh, if you have 5 grams of salt on a regular basis, I think one should reduce it by about 30%, 30 to 40%. So reducing your salt helps you in reducing a systolic hypertension. More important is to have a lot of leafy vegetables and vegetables in your diet. Occasional intake of uh, fish intake will improve your intake of omega fatty acids, but less of fried foods, less of oily foods would be very important. Regarding alcohol intake, it is said that excessive amount of alcohol can cause problems, and therefore limiting alcohol intake to 30 to 60 ml on a regular basis is permitted, but beyond that, it can have adverse effect and therefore needs to be regulated. So please don't consider that I have recommended alcohol on a regular basis. If you are taking alcohol, 1 to 2 pegs are regular. But if you're not taking alcohol, you do not start taking alcohol. Regular monitoring and follow-up are essential for patients with systolic hypertension. Blood pressure should be checked frequently, and adjustments to treatment should be made based on individual response and risk assessment. I think if a patient comes to you and the first time you found the patient to be hypertensive, there is no need to rush in to start treatment. What needs to be done is first have at least 3 different times when you monitor the blood pressure, assess the blood pressure, and establish the fact that this patient is hypertensive. Once you have found that this patient is hypertensive, I think initially 3 to 6 months, you can advise lifestyle modification. Lifestyle modification in the form of exercise, in the form of diet, in the form of meditation. Yes, I did not mention about meditation. Meditation is yet very important. Meditation and yoga forms an important basket of treatment of lifestyle modifications for patients with hypertension. And one should learn medication from a good mentor who can guide you the right ways of doing meditation. And yoga from a good yoga instructor, because basic techniques of breathing are very essential and are helpful in controlling your hypertension. So before you start the patient on any medications, I think it's important to assess and find out that this patient truly has established hypertension. Only once you have found that this patient has established hypertension, and after lifestyle modification, patient is still not responding in terms of reduction in blood pressure, only then you should get onto starting medications. But almost 60 to 70% of your patients, if they follow lifestyle modification, they will respond to plain simple lifestyle modifications. As far as pharmacology goes, I think what is important is a stepwise tailored treatment to the patients. And the various drugs which can be used are, you start off with small, milder diuretics. ACE inhibitors are the next in terms of hierarchy. Start off with small diuretics, then go on to ACE inhibitors. The next step would be to add calcium channel blockers. Generally, you start off with a monotherapy, but if monotherapy is not effective, then you can use a combination of ACE inhibitors or calcium antagonists. These medications, they help in controlling the blood pressure and reducing the cardiovascular effects of hypertension on individuals. ACE inhibitors, today we now have a newer generation of ACE inhibitors like sacubitril/valsartan, which also is now being promoted for controlling hypertension. Though sacubitril/valsartan is primarily used more for heart failure patients. There are other aldosterone antagonist inhibitor diuretics, which are also found to be useful in controlling hypertension. With most of these drugs, it is found that you can get 97-98% of the blood pressure under control. What is important is I mentioned about essential hypertension, but there is we've spoken about primary hypertension, but there can be secondary hypertension where there is a correctable cause. Secondary hypertension, like if there is, for example, if there's renal artery stenosis and that is causing hypertension, then you need to treat renal artery stenosis. Maybe you can contribute by putting in a stent and dilating the renal artery and providing relief to the patient. Or if the patient has got some endocrine problem like Cushing syndrome, that can also give rise to secondary hypertension. That's correctable. Correct the cause, and you will find that the cause is corrected. Sometimes patient can present with hypertension in the upper extremity, whereas lower extremity is normal. In such a situation, when you have a difference in upper and lower extremity, probably the patient could be having clot
Clear.
aorta, and that would
Got it.
require correction with uh, and with a quadruplasty and maybe a stenting of the aorta. So secondary causes need to be ruled out before you label the patient as primary hypertension. Once you have established primary hypertension, I think most important is primarily the first line of treatment is lifestyle modification. After lifestyle modification, if the patient still does not respond, then go on to management with drugs. Management of drugs should be in a stepwise manner. Start out with diuretics, add ACE inhibitors, add calcium antagonists, and then you have other paraphernalia of drugs. In the olden times, there used to be centrally acting drugs like Arcamin and Adelphine acetylate. These are today these drugs are lesser used, more because of the side effects and because of the presence of postural hypertension. Alpha methyl dopa was one of the drugs, but still these drugs like alpha methyl dopa, hydrolazine are used for treating patients with systolic hypertension and pregnant women. So these are drugs, though not used on a regular basis for systolic hypertension, but in pregnancy they are found to be quite useful in controlling. Now, the important drugs in pregnancy, which can be used for controlling, are alpha methyl dopa, hydrolazine, calcium antagonist, and labetalol. These are the four drugs which are used in controlling hypertension in pregnancy. So I've just given a bird's eye view of how systolic hypertension needs to be approached, what is the investigations, what is the management, and how you can help your patients in getting better treatment. I stop my talk now. If there are any questions, I can take any questions from you. Venkat, Prasad, Dr. Keshav,
Yes, yes.
anything you'd like to ask?
Is there any, I mean, regarding adrenal medullary tumor as such,
Yeah,
like pheochromocytoma,
yeah.
uh, how can we treat them? I mean, in that case, USG is required, or I mean, estimation of VM is required,
Yes,
vanillin Mendelic acid.
yes, yes.
So, how to proceed further in that?
See, I think pheochromocytoma, these patients have a sudden surge in blood pressure, which can be dangerous to the patient. And once you have established a diagnosis of pheochromocytoma, I think it needs to be surgically resected. So after getting estimation of Mandelic acid, today probably getting a CT abdomen will help you to define the size and the type, the site location and the type of tumor that you have, and a surgical approach would be the approach to removing the pheochromocytoma. Because another the very important thing regarding the pheochromocytoma is you need to locate the site. Sometimes pheochromocytomas may also arise from the lungs. So it is very important to locate the right site of the pheo and remove it surgically. Because no matter what you give, you may give alpha blockers, you may give beta blockers, you may try to control it, but those surges which occur because of pheochroma, they cannot be controlled and it has to be removed surgically.
Regarding whenever there is a resistant hypertension as such, so centrally acting moxonidine has been used of late, and whether it is of any use now in this case.
Yes, yes. In
I mean,
fact, see, elderly people, especially people beyond the age of 60, 65, you know, we normally go by the protocol-driven drugs, what are mentioned today, like calcium antagonists, ACE inhibitors. But despite giving all the diuretics, ACE inhibitors, calcium antagonists, they still don't respond to these vasodilators. In which case, I found that centrally acting drugs are very effective in controlling the hypertension. In fact, my mother, I had kept her on 4 drugs to control hypertension, and still the diastolic was remaining at 110. And then I switched her over to Adelphin Acidrex. And mind you, after switching her over to Adelphin Acidrex,
So it has
I
come.
had to stop all the other drugs and plain Adelphin Acidrex control hypertension. So though I think a lot of our medical practice also is governed to, I'm sorry to say that it is governed to a good extent by the pharma industry.
Hmm.
So it is very important that we as clinicians should balance what is right, what is in the interest of the patient. Adelphil Acidex today may not even be available because the cost of the tablet is 10 paise per tablet.
It's not available, sir, really.
It is not freely available. So,
Yes.
in fact, last month itself, I had to switch one patient to Adelphil Acidex, and the BP has come under control. So, in elderly patients, especially centrally acting, but one has to remember that centrally acting, especially Arcamin, you should advise the patient that they should not stop it suddenly. What happens is elderly patients tend to forget taking their medicines. So they have to be monitored very closely in terms of what medicines they're taking, how they're taking it, whether they're taking it regularly or not. Because stopping Arcamin suddenly can cause a rebound hypertension. So we need to be a little more careful. I think most fundamental thing for all of us to do is spend a little more time with your patients. Trying to understand how they're taking their medicines, a little more, a personal touch the patient to understand whether they're taking medicines regularly. Dr. Saab, you mentioned about resistant hypertension. I think if we take a proper history, if we find that the patients are taking their drugs regularly on follow-up, they are taking as per the advice given to them. Resistant hypertension is a thing of the past today. Most hypertensive patients come under control.
Yeah, the so-called difficult to treat hypertension, as you said, it's actually incidence is not so high. Maybe very few cases of renal artery stenosis, pheochromocytoma, etc. might be there.
Yes.
But the most important part is the patient counseling.
Yes, counseling is very
Even
important.
beta blockers also sudden stoppage
Yes.
cause a lot of problems.
Yes, beta blockers sudden stopping can precipitate infarct. So
Yes.
therefore, I think giving a little more time to our patients and taking a proper history, discussing with the patients goes a long way in managing our patients and treating them better.
Among this thing, I mean, hypertensive, antihypertensive tablets. See, regarding this calcium channel blocker or ARBs, uh, I have found, I mean, regarding as far which is the most suitable ARB as regarding sartans. I have in my personal listing, I use azilsartan more with as compared to an olmesartan. So which one you will prefer?
See,
Azilsartan gives
I,
more this thing
no,
as a
no. I think ACE inhibitors is a class effect. Any of the ACE inhibitors would be more or less similar in their impact on controlling hypertension. So if I have to say, some ACE inhibitor would have a particular benefit
No,
over.
I'm talking about ARBs. Azilsartan I'm talking.
I know whether it is ARB or ACE inhibitors, I
Hmm.
think the impact on controlling blood pressure is more not. I mean, there's no significant advantage of using one over the other. It's your
Okay.
choice. Maybe the later generation ACE inhibitors or ARBs would probably have lesser side effect in terms of the cough, persistent cough which the patient gets because of ACE inhibitors. ARBs have lesser incidence of cough, but in terms of superiority, really not much difference between one over the other.
Again, that is also very industry driven. They say a lot of things about calcium blockers, that. But I think they are almost class effect only,
Yeah,
as
most
far as I know.
I agree with you, Prasad. I agree with you, Prasad. Yeah.
And especially while reducing, what about nicardiads such as compared to calcium channel blockers? We get here cilnidipine is now widely used. But in case of systolic hypertension, if it is only there, and we want to reduce this thing, which one is preferred in the calcium channel blockers?
See, we have more data about Nicardia. Nicardia is now existing for maybe around 40 years. When it first came,
Yeah.
we did the trial at Sion Hospital with Nicardia.
Yes.
So we have got more experience with Nicardia as such. But the incidence of pedal edema is more with Nicardia as compared to uh, the later generation, cilnidipine.
Yes.
Okay.
Yes.
Yeah. But in terms of effectivity, I think it's a class effect of calcium antibiotics. Yeah. They say that yes, cilnidipine has a better control, this, that. But Nicardia, in fact, if you have retired, then it is more prolonged in action. And
Yes.
so it's an individual choice. You can choose between either of them. That should not be a problem.
Okay.
Yeah, nifedipine in particular, actually the extended release preparations are only to be used,
Yes.
not the
Yes. Yes.
other ones.
Yes. And very important is in case if a patient comes to you with a very high blood pressure, you should not suddenly bring it down to normal. Because these patients,
It is
the
slowly.
organs are perfused at high pressure for a long time. So what you should do is, if you want to control the blood pressure, get it down by about 20%, 30%, and get it down in a stepwise manner. Don't rush in to get a patient with a BP of 200, 220 down to straight 130, 140. This patient will, in fact, he will stop your medicine because he will say that the medicines have not suited me. Yeah. So it's very important that in such patients, bring it down in a gradual manner. I mean, and a hypertension, yes, is dangerous, but bringing it down suddenly and a crash in the blood pressure itself is a problem. So get it down in a stepwise manner.
Maybe except in hypertensive encephalopathy, which is an emergency. There, I think a little bit rapid reduction is required.
Yes, I think I agree with you. Venkat. In an emergency cases, you may get it. Even there, the recommendation is get it down, keep it at 160, 170. Don't get it down to 130, 140.
Okay.
Yes, because the perfusion of the cerebral perfusion gets affected. And this patient, if you get it down suddenly, will feel extreme level of exhaustion, fatigue, disorientation. They may not even take your medicines. So go in a stepwise manner and get it down slowly. That would be more useful for the patient and ideally recommended.
But in the process, any intracerebral bleeding may take place, hemorrhage in that case. If
See,
you don't, I mean, when you are treating in a clinical, in your clinic as such, as not being monitored here in the house and all. So that's a risk we have to undertake.
that is a small
for
risk.
graduate.
That is a small risk which you have to take. But you have to explain, as Dr. Prasad said, counseling the patient is very important, and talking
Yes.
to them before that. Such a high blood pressure, the risk of hemorrhage is always there. So it is better to get it down. We need to get it done in a staggered manner. Counseling is very important, and especially with the patient and the relatives. So the relatives there to take care of the patient.
Another thing is that regarding verapamil, where it can be used, verapamil, calcium channel blockers.
See, verapamil primarily, if a patient has got a COPD element, okay, and patient has hypertension, in such situations, one would use verapamil, where it does not have an impact on the respiratory system. Okay, beta blockers for such situation would aggravate the bronchospasm. So in such situations, you would use diltiazem for controlling blood pressure. But today, by and large, diltiazem is not the first line of treatment.
Particularly when there is
fibrillation,
when there is
atrial-
tachycardia, when there is tachycardia and we cannot use
Yes.
beta blockers to control the heart rate,
Yes.
verapamil is a good choice actually.
Yeah. Tachycardia and respiratory problem, then you can't use
Oh.
beta blockers. Then,
Beta block, yes.
then diltiazem would be the choice.
What about atrial fibrillation with this one? Hypertension?
See, atrial fibrillation with hypertension, I think number one, ACE inhibitors would be useful. I think any of the drugs which control the hypertension can be used in patients with atrial fibrillation. But patients with atrial fibrillation would also, in addition, require anticoagulants. to prevent the
uh,
risk of thromboembolism. And the second most important point is one has to control the ventricular rate. Okay. In such situations, ventricular rate will be controlled by number one, beta blockers. Number two is diltiazem. And if required, you may add amiodarone or cardarone to the combination of drugs. Yeah. ACE
so
inhibitors, of course, can be used. In such situation, in fact, calcium antagonist, you should keep it lower down.
okay, okay, okay.
Because calcium antagonist, especially nifedipine, will get the BP down, but it will also increase the heart rate still further. So in patients with atrial fibrillation, the aim would be to keep the heart rate under control and at the same time control the blood pressure.
Okay.
Yeah.
So it is not mandatory that amiodarone with verapamil is always used in atrial fibrillation that way.
No, no, no.
I mean, because most of the patients we have seen here, there is amiodarone with verapamil was there. So I had a little doubt about this thing. That's why.
No. See, another thing, people, again, pharma driven, for everything amiodarone, any tachycardia amiodarone is left, right, and continued. But if you realize, and if you have to take amiodarone itself, you go through the literature amiodarone, you'll find how toxic that drug is.
Yes, yes.
So I think we are saviors of mankind, and we need to use drugs rationally and appropriately. Use them judiciously for the benefit of mankind, rather than for the benefit of the pharma industry.
Mhm. Among the calcium channel blockers, which one will you prefer? I mean, cilnidipine is widely this
Yes,
thing.
yes.
What is the advantage of benedipine and other these things?
No, I don't think we have. See, what generally I'll tell you what we do is we prefer drugs which have got more data, more experience of use, and more literature. Those are the drugs which we generally go in order. See, now like benedipine, some company will come out with benedipine, some company will come out with some other drug. But if we don't have large data, we go by data. We are driven by data and what is available as literature to us. More experience, more data on nifedipine and now cilnidipine. Benedipine is we don't have much data on that. Therefore, benedipine would not be higher up on our list of prescription.
Okay.
See, our very familiar amlodipine, except for the pedal if it develops,
Yeah,
otherwise that is a wonderful drug. It is so cheap. I mean, it's excellent experience.
I agree with you, Dr. Prasad. Absolutely. So I think
think
we will,
finally, Dr. Kokani always used to say about fixed drug combination, which is an excellent idea
yes.
because we can use suboptimal doses of multiple drugs where they act at multiple levels
Yes.
and whereby the side effects of each drug will be much less.
I agree with you, Dr. Prasad. Today, in fact, they have a combination of drugs, and you just have one pill which has three drugs in it. That is, see, that improves the ease of taking the medicine.
Absolutely.
If I have to take one TDS drug, another drug which is TDS, over a period of time, I will tend to forget one of the drugs, and automatically the amount of drugs that I take comes down. Whereas if it's a single pill, the convenience of taking it and the combination of drugs will have lower levels of drugs and lesser side effects.
And there are multiple mechanisms of action at different levels. So
Yes,
that will have a very coordinate, what you call that, very good effect in overall control of hypertension.
you're
Like
right.
synergistic action type of
You're right.
technique.
There is one question here. What is or should be the threshold for starting antihypertensive to a newly diagnosed patient? A newly diagnosed patient, I think one should actually, as I said, give him a trial of lifestyle modification. Wait for 3 months, wait for 6 months. There is no hard and fast rule that you need to start the medicine in 24 hours. Give a good trial of lifestyle, and I'm telling you, 70% of the people will be controlled by plain lifestyle modification. Don't rush into start medicines. Because once you start medicines, then more or less you have to continue on a long-term basis. So I hope it was informative, and we continue to have this program. In fact, this program, through this program, we are reaching out to interior districts of Maharashtra, to doctors who don't have access to medical education. So we are trying to improve their skills in handling patients and improve and have better patient outcomes. This will be conducted presently once a month, but if everything goes fine, we may increase the incidence to maybe once a week also. I thank all of you for attending this CME and participating in the discussion of systolic hypertension. Our next topic will be announced in a short time, and it will be conducted on the last Saturday of every month. Thank you all for attending this CME program. And this is, as I mentioned earlier, this is as a mark of respect to all our teachers who have taught us everything and on whose shoulders we stand tall.